Good afternoon and welcome to the Way Into Nephrology Nursing presentation to discuss exploring nephrology nursing as a career choice. I am Dr. Amber Paulus. I am the chair of the leadership committee for ANNA, and we'll be sharing some pearls of wisdom from my career in nephrology nursing and some of the different career options available through our profession. So let's jump right in. So a little bit of background. The historical context of nephrology nursing. It was recognized as a specialty over 45 years ago, and it's essential in managing CKD, dialysis, and transplantation. So we talk about the three patient population groups within our profession. The first is those who exhibit disease symptoms. That's risk factors for chronic kidney disease. And then we identify, diagnose, treat, and manage those with chronic kidney disease. And the disease runs on a spectrum. So stage 1, 2, 3, 4, 5. Stage 5 is classified as end-stage kidney disease, and at that point, we're looking for ways to do renal replacement therapy, so dialysis or kidney transplant. And then federal funding for changed the way that we funded that end-stage treatment modalities, primarily dialysis. Medicare coverage was extended to individuals who have end-stage kidney disease, and so they were entitled to Medicare, which was traditionally an age-eligible, being 65 years or older program, but the disease gave them access to that insurance opportunity. Federal funding is expanding access to dialysis and transplantation, and growth of the nephrology nursing roles and specialized practice developed from there. And then up until 2019, we saw our association primarily with dialysis. So most nephrology nurses worked in that setting. There was a lot of the care is taking place in dialysis facilities across this country. But then today, since a lot of policy changes that happened in 2019, and more recently, we've seen this upstream progression, and we'll talk a little bit about that here in a minute. All right, the scope and role of nephrology nurses. So when you're in nursing school, you learn a lot about roles and scope, what you can do in comparison to what your peers can do, who have different credentials in the clinical setting. The nursing process and patient care. So we care for patients of all ages. There's pediatric clinics for those who need dialysis or transplantation. And then all the way to geriatric, so until the end of life, involved in all aspects of patient care, from assessment, planning, implementation of a care plan, evaluation of that care plan, and tweaking it to meet patient needs and their desired quality of life, and then providing individualized evidence-based kidney care. There's, in dialysis specifically, there's a lot of protocolized medicine where we manage to various clinical practice guidelines for mineral metabolism, anemia management, vascular access management, and those kinds of things. So there are a lot of standardized practices that you learn in that setting. Upstream is still newer age medicine that traditionally would have been covered through like family medicine, primary care. There's a lot more opportunity for nephrology nurses to work in that setting for those who recently diagnosed or managing comorbidities like diabetes, hypertension, cardiovascular disease, to try and protect their kidneys, keep their kidneys healthy, and prevent disease progression to end-stage kidney disease. So that's where disease prevention and health assessment comes in. I wouldn't say it's new, it's just newer in the specialty, in the sense that we have been traditionally a sick care model where we're kind of focused on the end state. There is much, much more opportunity. Companies that exist today that didn't 5 years ago for nephrology nurses to do population health management and care coordination. And the goal there is to educate patients and families to prevent kidney disease or slow its progression, focusing on lifestyle modifications, the early detection, so using a lot of data science, predictive analytic algorithms, and risk management. So doing care visits that give us kind of an annual wellness baseline, and then framing a care plan around that. And then comprehensive health assessments, looking at both physical, emotional, and psychosocial needs. So I think across all specialties, this isn't unique to nephrology, we're looking at how unmet social needs correlate with someone's mental health and well-being to their actual clinical health. All right, so a few fast facts about the disease. So 37 million Americans and more than that have chronic kidney disease, because this is what we're able to capture through surveillance data. There's many, many more who perhaps have it and don't know. It's the 8th leading cause of death in the US. 1 in 3 adults in the US are at risk for CKD, and we know that based on the 2 primary causes are diabetes and hypertension. 2 out of 3 new kidney failure cases are caused by those comorbidities. And so the risk factors are quite prevalent, especially in this country. Non-Hispanic Black adults are 4 times more likely to develop kidney failure than whites. And there's a lot of good research going on right now as to why that is so. A lot of it has to do with access to care, awareness. Early detection is possible with simple blood and urine tests, but those aren't just highly prevalent in communities outside of like traditional medicine. And so I'm leading research in that space to look at how we can take these simple tests into the community and meet people where they are, because there's a huge lack of awareness of personal risk for and diagnosis of kidney disease because it's a silent disorder. And most people don't know they have it until it's quite advanced and they start to experience physical symptoms from the disease progression. All right, so now let's talk about some of the roles that are available in nephrology nursing. So a staff nurse, which is a common role across specialties, is an option in nephrology. So this is direct care for patients who are undergoing dialysis or for managing kidney disease. So you could work, I think I'll talk about settings next, but you could work in a variety of different settings in this particular role, but it's hands-on care, so physically taking care of patients. And there's home dialysis, which is kind of unique to our like modality offerings, the way we treat kidney disease, the way we do renal replacement therapy. And it's supporting patients to do dialysis like you would do if you were a staff nurse in an outpatient hemodialysis clinic, but doing it in their own home. And we use a lot of remote monitoring tools and data collection to help support and manage patients in that setting. A vascular access coordinator. So the thing that is true about our specialty is a lot of the work requires a lot of coordination across specialties. So the best dialysis we can offer, if that's the modality of choice for a patient or the treatment type that we're going to offer, is usually a fistula. And so the patient would need surgery to create that so that we can access their bloodstream and clean their blood through a dialysis treatment. And so someone who's coordinating like the surgery, the access has to mature, and we have various we can clear it for use for an actual dialysis session. Just requires a lot of coordination. So there's an option for a role in the setting. And then a transplant coordinator. So much like a vascular access coordinator, if a patient wishes to not start dialysis and pursue transplant instead, that's an option, preemptive transplant. Once a patient's GFR or their kidney function is at 20, they are eligible to pursue a kidney transplant the way that the organ allocation or waitlisting management system is set up in this country. And there's a lot of coordination that has to go on there. We do comprehensive medical assessment of the patient. We get data from a variety of locations of the patient. They have clearance tests like cardiovascular clearance tests and screenings for other comorbidities that may exist and medication management. And can they financially support the immunosuppression drugs they'll have to take after, coordinating the finances, so insurance coverage. A lot of coordination has to happen. Also just referral management in general to get patients into the process. There's coordination aspect of that. And so transplant coordinator is a huge opportunity for a role in nephrology nursing. The next is nurse manager. So kind of looking at a different type of role. This is administrative. So now responsible for not only nurses, but patient care technicians if you're in dialysis, social workers, dietitians, collaborating with pharmacists, depending on your setting. And so you're overseeing staff and operations in a variety of units. So maybe acute care, so inpatient dialysis or outpatient within a transplant center. So managing a number of coordinators. It can be set up in a variety of ways, but your function is more administrative, ensuring that the staff and team have what they need to accomplish the patient care. And then a nurse practitioner. So the advanced practice nurse in the nephrology setting is a highly needed role, so providing advanced care, diagnosis, and treatment in nephrology settings. I would say with this push to value-based care we're experiencing in the field, in the specialty, the need for a nurse who has nephrology experience or desires to gain that. I know that in nursing school, in nurse practitioner school, there is a huge emphasis on nephrology, so a lot has to be learned on the job. It is a advanced practice that is hugely needed in doing ongoing treatment and management of patients with kidney disease. So having that specialized knowledge. All right, and then where can you work? So some practice settings. So I've mentioned a lot about dialysis clinics. This is a physical building, an outpatient dialysis center where a number of patients are on shifts traditionally 3 shifts. It can be Monday, Wednesday, Friday. It can be Tuesday, Thursday, Saturday. And clinics operate on varying schedules where patients do their treatments kind of at stagger starting times in the same room together. Hospital, and that can be inpatient and in a hospital where it's happening. They've been admitted and they need dialysis treatment, and then outpatient in a physical building somewhere where they're accessing it on a regular basis. Hospitals, so it's the dichotomy I was describing before, acute and outpatient. Sometimes too, like depending on the size of the hospital, there may be specific, what we historically had called wards, floors, I think is really the terminology we use today, where a bunch of patients are kind of located there because they have similar kidney diagnosis. And so it just kind of depends on how the hospital is set up. Sometimes they would be embedded in a med surg floor, sometimes on a PCU, and obviously on an ICU if they're getting CRRT or something like that. Home settings. So this looks different in comparison to different companies that are doing home dialysis. This doesn't always mean like home health nursing, where the nurse is like physically going into the patient's home environment on a regular cadence. Patients train for home traditionally in an outpatient setting, and then they go home, and there are various intervals of going to the patient's home to observe for things or meet them there if that's easier. But it's not like home health nursing. Those are very different setups of care. Now, there are new companies that have come on the scene that have started to model a home health type of approach, and that is something that's kind of new and innovative, different from the traditional way home dialysis has been put together, monitored, and managed. Long-term care facilities, this one has definitely increased in its prevalence. So this is dialysis in a nursing home. You can imagine that there's a lot of coordination that has to happen for a patient to get from the nursing home to a dialysis facility, back to the nursing home. And so a lot of nursing homes have started placing what's kind of called den dialysis. It's inside the nursing home. The patient doesn't have to leave their home to do it. And so opportunities to do that kind of dialysis in that setting. It's not always elderly patients. Sometimes it's those who are there for rehab and short-term stays as well. And then transplant programs. So I mentioned the kind of role associated with that, but there are several roles. There's also like quality roles where you're managing. There's a lot of data we have to report around transplant. So coordinating, providing care for patients who are pre-transplant, so working up towards a transplant, and then post-transplant, they've already had a kidney and we're managing them post-op. And then outpatient setting. So specialized nephrology care, there's a lot of opportunity here for like remote roles where nurses are care managers or care coordinators working from their home setting and managing a panel of patients. So we use technology that gives you information about the patient's interaction with the care system, and it's your job to call them and coordinate their care. So do they have all their medications? Educate them about signs and symptoms and what level of care they should access. So they should call their care coordinator, call their physician. They should be seen in the office before they escalate to an acute care setting. Lots of opportunity in that kind of role. And it's really a non-traditional setting because it's not exactly a physical place. Nurses kind of are everywhere, and they're working for places like health plans, the value-based care organizations that have kind of large dialysis organizations that have diversified their business model, providing opportunities for nurses to do this kind of work. All right, challenges and rewards. So one of the greatest challenges is the patient population is extremely complex. And so having a deep understanding of anatomy, physiology, the way that your diet can impact your minimal metabolism status, anemia management, really how the kidney functions and how its lack of function negatively impacts your body. The various interventions you can do to manage comorbidities like hypertension, diabetes, so monitoring your blood sugar, obviously diet modifications, managing your weight so that your BMI stays within a normal range, but also your distribution of your body type. So a waist circumference, having a larger waist circumference than is normal for your gender can be a risk factor for kidney disease. And so kind of thinking about all these factors that impact your holistic care makes it complex to manage the patient population. The other thing is there's usually this kind of marrying of cardiovascular disease and CKD. and it's hard to determine which one happened first because the kidney is not working appropriately, puts a lot of strain on the heart. The heart having to manage a fluid volume puts a lot of strain on that and ultimately impacts your kidneys because of damaged nephrons. And so it's clinically dense, but the more time you spend in the field and understanding the way that the organ we're primarily interested in works, the easier it becomes to start thinking about the complexities. If I do this, it will do that. If I do this intervention and result in this, but it requires having tailored care plans for each patient's unique needs. And then a holistic approach to patient care. So addressing emotional, social, and psychological aspects of kidney disease. Again, you see this across care or specialties. So how unmet social needs can impact your clinical health and providing education and advocating for the patient needs within this healthcare system. A note I will say here is that the way that we capture this data has been a challenge, capturing like social determinants of health, but specifically for those individuals who are in stage disease, we have a registry system. It's kind of like very unique to nephrology, but it allows us to capture unmet social needs when we entitle patients to Medicare. It's really difficult to understand, but basically for every patient who is classified ESRD, we fill out this form, it gets submitted to the federal government, and they add them to the registry. So now we have that social determinant health data at the start of dialysis. I hope going to start expanding throughout the system. Hospitals have similar things where they're required to capture and report social determinants of health. It's still in its infancy though. All right, so specializations within nephrology nursing. These are called therapy modalities. So I've kind of alluded to these as we've been going, but I'll be more clear here. Hemodialysis is administering and managing insulin or blood purification treatments. We're cleaning patients' blood, and you can do that in a center, so in a physical facility. And then HHD, home hemodialysis, is doing that same work in a patient's home. Transplantation is pre and post kidney transplant care, so patient education and monitoring, and then home dialysis. The work is actually like training and supporting patients performing dialysis at their home. And you can do HHD, what I first described, and then peritoneal dialysis, which is most simply described as dialysis through your belly, using your peritoneal space, and then offering the patient greater independence to kind of do their treatments as it works best to them. Because if they're in a center, they have a chair time, and they're going to have a run time, and they're going to do it 3 days a week at least. And that, they have to physically be there. It's like showing up for a job. It can negatively impact your quality of life. There's minimal flexibility because you can't just change on a whim. There is some flexibility, but it requires a lot of notification to manage that. Continuous renal replacement therapy. So this is primarily in ICUs. It's critical care dialysis for patients with acute kidney injury that we believe. So we think about kidney disease on a spectrum, AKI as like lightning bolts that creates this acute injury to the kidney. And we hope that it would resolve if we do these specialized treatments. Conservative management is the focus on palliative care. So symptom management for patients who have decided that, yes, they have kidney disease, but for their desired quality of life, they don't want to go on dialysis. The first 90 days of dialysis for anyone, even those who are of younger age that unfortunately have kidney disease that has caused failure, their kidneys are no longer working, it's a very volatile period of time. And there was a recent article published that said that starting dialysis for certain populations, primarily elderly, will only extend their life 77 days. And so it's kind of weighing that. Do I desire to have like a quality of life that doesn't require me to spend my days in outpatient dialysis? Or can I be medically managed where like my symptoms are going to be medically treated to the best of, what modern science makes available to us until, my last days on this earth? And that's an equal option for patients to pursue in lieu of a kidney transplant or dialysis. And then peritoneal, we talked about this with home dialysis, but HHD, the difference is for home hemodialysis, we have to have a vascular site that requires a needle to access. You can have a CVC, which, central venous catheter in your chest, which you can just connect and disconnect lines. But peritoneal dialysis is a catheter through your belly that doesn't require cannulation, how we access with a needle, a fistula, or a graft. All right, emerging specialties. So I've also alluded to these, but I'll be more clear here. So upstream disease management. Again, I think if you ask most nephrology nurses, a lot of them would say somewhere in their career they've spent time in dialysis, either working there, managing there, getting a lot of nephrology experience in that space. And if you talk to anyone in nursing school and you ask what their exposure to nephrology was, they might say, I had a day or like a few hours exposure to dialysis while as a nursing student. Upstream management is, we're starting to think about population health. So it's become extremely expensive in this country to have all of these people who are on dialysis. Like, as technology has gotten better, people survive a lot longer on dialysis, which is wonderful. But like, what would it look like as a country if dialysis became like the anomaly, the extreme treatment that we had to give patients because we've done such a good job managing upstream, so keeping people healthy longer. So focusing on early intervention, slowing disease progression, and preventing the onset of end-stage disease, and being proactive with our strategies to reduce hospitalizations because we manage comorbidities. We have these care teams who are proactively reaching out to people and saying, here is how you should access care. Here's what care escalation appropriately looks like, and that can create some cost containment, because people who aren't nurses or trained in clinical settings don't know what they don't know. And so if they're not feeling well and they're concerned about their well-being, they're likely going to go to an ER. They may go to an urgent care that might not be available in their community. It just depends. But waiting for an appointment to see a physician could be a long period of time. And, the time is of the essence when they're not feeling well. So there's a lot of opportunity with upstream disease management. Optimal starts to dialysis is also another way to kind of think about, I wouldn't call it a specialty, but it's like a specialized intervention that is relatively newer. So these are patients who, we've known about for a while. There's really two sides to this coin, but I'll talk about this first population first. So we know they have CKD, they've started to progress. We can see their GFR trend. GFR is the lab value we use to look at kidney function. And once they hit a certain level, typically 20, a GFR of 20, we start saying we need to do modality education, because it's likely, and there's equations we can use for this. The kidney failure risk equation tells us the likelihood a patient will start dialysis in 2 or 5 years. So once the score starts to reach a certain level, usually around 40%, we'll start to say, I'm concerned about this patient needing dialysis in their lifetime. We can use a second equation, which is new. It's called Kidney Predict, where it shows competing risks between dialysis start and mortality, the likelihood a patient would die, really succumb to their other comorbidities, not necessarily driven by their kidney disease. And that helps us to know, like, we don't need, every person doesn't need to start dialysis. It really depends on what they want. It is a life-sustaining treatment, but it's not always life-prolonging, where you get abnormally more days because you were on dialysis. It kind of just depends about what's going on with your entire medical history. But optimal starts prepares patients for what they may need, which is dialysis, through modality education. So you can do home, kind of what we just talked about. You can do home dialysis. You can do home dialysis with a needle cannulating a graft or a fistula, or you can do it with a catheter in your chest. That's not ideal. That would not be optimal dialysis because there's so much risk for infection. And then you can do PD, which is, dialysis through your belly, or you can have a kidney transplant. We can work to identify a living donor, or you can get on the waiting list when your GFR hits 20, you start working up to be placed on the wait list, and you can start dialysis in a planned way. The other side to this coin is what we call crashing into dialysis. And that creates a lot of strain on the system, a lot of strain on the staff, a lot of strain on the person. And so the idea is that we have so much opportunity, we have so much data, we have this relationship with these patients, and so we can transition better. The last one here is reducing hospitalizations, primarily in the dialysis population, but we like to see it really across the board. And that it requires training. Like I said, like, not everyone has medical training where they say, like, I need to go to the ER for this thing. Like, if they're concerned about their well-being, they're probably going to go there. But if you know what their disease states are and you know how they're being treated, did they run out of their medication so they haven't been taking it? So that's what's leading them to feel poorly. Or did someone change the medication? Because a lot of prescribers see our patients, nephrologists, cardiologists, endocrinologists managing their diabetes. And if someone changed something, the other person might not know, and it's creating issues. And so this allows us to align our incentives for value-based care that ultimately will impact cost and hopefully quality and the patient's experience of their care. All right, qualifications. So The knowledge base, this is primarily what you learn in nursing school, core areas of anatomy, physiology, pathophysiology, pharmacology. Knowing pharmacology really helps. I will say you understand that so much better when you are actually in the specialty, regardless of what specialty you choose. So you don't have to remember everything from pharmacology, because it's going to be the drugs that your patients take that will start to adhere to your mind, and you'll be able to recognize those because you see it in real practice. Specialized skills. So specifically for this population, nutrition, growth and development, and then patient counseling. That is a skill, and you get better at it over time as you do it. But it's definitely something to consider if nephrology is interesting to you. Team collaboration, knowing who's on the team, usually like in the dialysis setting, social worker, dietitian, the physician, and sometimes a nurse practitioner collaborate together to accomplish the patient care. You also have medical directors who are more like a leadership position, but they're physicians assigned to different dialysis facilities. Upstream, you'll probably have a pharmacist on your team who's helping look at all the patient medication lists and reconcile them and ensure that we're not taking competing medications. But knowing who to ask and how to reach out to them to do and plan patient care is really important. And the last one here is research. So understanding, just a basic understanding of the research process, looking for opportunities for evidence-based practice and how we can translate evidence into practice faster. The gap between those is 10 years. And so accelerating that only makes care better for the patients. And then continuing education. So lifelong learning. I still learn something new every day. It makes it interesting. It's why I stay in the field of nephrology. I'm really connected to the American Nephrology Nurses Association, and it's offered me endless opportunities through the various programs, publications, conferences, to experience professional development. So the nurse that I was when I graduated nursing school compared to the nurse I am today is radically different. And a lot of that is because I met people in A&A who gave me an opportunity to try something that built a skill set that furthered my career and the opportunities that I had access to. We do have a certification. So through the Nephrology Nursing Certification Commission, there's actually several like CDN, CNN. If you're a nurse practitioner, you can get the nurse practitioner equivalent of that. So you have to meet the eligibility criteria, which has some hours requirements, passing an exam, and then maintaining that certification through ongoing education, CEs. And then the benefits of that, obviously professional credibility, improving the patient care. It's basically a reflection of your knowledge base and that you've been able to care for this patient population. And then obviously for career advancement. If you read job descriptions, so if you're ever interested in a job, you start reading job descriptions, it's going to call out the things that they're interested in seeing. That definitely will take you a long way. It also makes your knowledge base sharper. So when you're studying for a certification, you are reviewing information that's naturally going to help you at the point of care. And so I say the smartest I ever was whenever I was studying for a certification. And then that information will start to hardwire in your brain as you start to use it in practice. Role development activities. So quality improvement is huge in this specific field because there's always something to innovate and improve on. So knowing those skills can be really helpful. Research application, I mentioned that on the last slide, and then continuing education. It's really fun to learn with other nurses. You know, like when we graduate, we don't know everything. You actually realize how much you don't know when you get started in the field or any specialty that you pursue. And it helps you stay current. Like there's a lot that's changing and it's changing every single day as new care models start to advance from this kind of push towards value-based care. It's changing what we're looking at. It's changing how we're doing the work that we're doing. And so organizations like ANNA make those available, make various opportunities available to stay current in what's happening in the specialty. All right, so a little bit about ANNA. The mission is to improve members' lives through education, advocacy, networking, and science with the vision of influencing kidney health through the expertise of nephrology nurses. And there's about a little over 6,600 members. We operate locally through chapters. I'm in the Old Dominion chapter 279. We do have 2 virtual chapters, and then we have 9 committees. The work of the organization is kind of broken down throughout those committees. So I mentioned at the start of this, the chair of the leadership committee, we do various projects that aim to expose and share how nurses can lead in this specialty. We also welcome students into the organization because you don't perhaps know that you would be interested in the specialty, and that gives you an opportunity to be exposed to it. And then we have specialty practice networks. So that kind of breaks down everything that I shared with you about different settings you can work in. There's usually a spin for each one of those. And then we offer awards, scholarships, and grants every single year. They're available on the website to look through, but it can help do professional development, writing for an award, scholarship, or grant, depending on what you're interested in. There's usually something there for everyone. All right, so the professional representation. So we are the American representation of our specialty. And we specialize in areas like I listed before: hemodialysis, CKD, peritoneal, acute care, and transplantation. We do develop some clinical practice guidelines. It depends on the committee work and what they're focused on. I specifically, with my colleagues, write for the Nephrology Nursing Journal to get what's happening in the field, like out in the industry, into the science and framing research that helps us understand that better. And then ANNA is committed to enhancing quality patient care through continued education, research, and teams-based approach, and that nephrology nurses are uniquely positioned to improve care for individuals with kidney disease. So we spend the most time traditionally with the patients in any care setting. So talking about student membership, it's free for 1 year. It's for any nurse who is not an RN and enrolled in a program. And you have all the privileges of active membership except for voting. We do elect a board, and so wouldn't have that privilege. But you also do not receive the print materials, but you can access them online, and you're emailed when they're available. And honestly, that's the primary way that's that information. So I don't think you're missing out on anything there. You can get on ANNA Update, which is kind of a collaborative forum that you can talk to other folks in the profession, attend a conference, register for those online. Career building opportunities, leadership opportunities. There's always a conference that's on its way, leaving this week to attend the Nurse Summit, I think it's been rebranded as. And then policy shaping. So actually, I had a reminder today on my own social media that this time last year, I was in DC doing advocacy work with ANNA. And so those kinds of opportunities are always upcoming and on the calendar, and you're available through the website if you're interested in that. Other resources. So we have several textbooks, the Contemporary Nephrology Nursing. I'm actually working on the update to that. We have a certification review guide that you see on the far right there. Scope and standards of practice will help you get more information on like what the role, how it operates in various settings if you want to go deeper. And then core curriculum, I call it like it's like the core text of everything you would want to know in nephrology nursing, whereas contemporary is more specific, it has more specific topics. You can actually use core curriculum to study for the certification as well. It's much more dense. It's a huge textbook if you're interested in that. All right, Connected, ANNA Connected is an online social and professional networking resource for ANNA members. There's a link for that. Folks are always asking like clinical practice questions. How do you do this in your clinic? This is how I do it. And so there's always something interesting to read there. And then I think, do we have time for questions? So if there are no questions, I think maybe I'll conclude with this. So I have been in nephrology nursing specifically since 2015, and I would encourage you, like if you're just interested to know more things that I didn't perhaps touch on, I encourage you to go to the website. The website has been rebranded, and so everything you could imagine that you'd be interested in knowing is available there through the various drop downs. If you're interested, so if you're not a student and you are a nurse and you're interested in joining, you can always get plugged in right away. I think everyone thinks you need experience within the, just being a member before you can start getting in there and being involved. There is no startup time. You just start right away because you have something valuable to offer to the specialty. And it helps with the longevity of your career in nephrology because you get connected to other folks who are having similar experiences to you, from staffing struggles to opportunities for professional development and kind of encouraging each other on in your careers. So I think with that, I don't see any questions. And so I thank you for your time and attendance, and I hope to see you inside the organization.